to all of us is pre-IVF counseling. So normally we have IVF, we have counseling, etc. But what are the things to do before, and what are the important aspects of that? To discuss about this, we have with us Rekha ma'am. Ma'am doesn't need any introduction, but however, I'll just say a few words about ma'am. Ma'am has done her fellowship in reproductive medicine. Ma'am has a diploma in hospital administration. Currently, ma'am is a medical director of Miracle IVF and Chandana Hospital, Bangalore. Ma'am has having more than 14 original articles and research papers. Ma'am has given more than 40 radio and television talks. Ma'am has held a variety of positions. Currently, ma'am, as I said, is a medical director of Miracle IVF Hospital. Ma'am has been the speaker, chairperson, moderator, and panelist in more than 200 state, national, and international conferences. Ma'am was a teacher of MS Ramaya and the Bangalore Baptist Hospital. Ma'am has a lifetime membership of many prestigious societies like BSOG, FOXY, KISAR, ISAR, IAG, PCOS, Society of India, IFS, etc. Ma'am was a EC member of BSOG 4 years. Ma'am was a joint secretary of BSOG 2019-20. Currently, ma'am is the secretary of BSOG 2020 to 2021. Ma'am was a EC member, the Indian Fertility Society, the Karnataka chapter, between 2019. Currently, ma'am is still the EC member till 2021. Ma'am was a member of the FOXY Infertility Committee, Endocrinology Committee, and the Food and Drugs Committee, headed by Dr. Vidya ma'am. Ma'am was also the core committee member, reviewer, and judge, the poster and paper presentation committee of ASCOG 2019. So with this short introduction, I would like to hand over the podium to ma'am and request ma'am to give her talk. Over to you, ma'am.
Good evening, all. Thank you, first of all, to all of you for sparing your precious Sunday to listen to me. I'm going to continue my talk, and it is on pre-IVF counseling. Hello, I'm audible?
Yes, ma'am, absolutely, ma'am.
Yeah. So pre-IVF counseling, I selected this topic because I thought it is very precious and very important topic. As we go through the slides, all of us will definitely realize how important the topic is, because we do a lot of IVF. Everybody nowadays has a lot of centers, but ultimately that counseling part is somewhere missing, I feel, which is the bondage between us and the couple. Let me proceed. Sometimes it helps just to talk to someone who will just listen and not judge us. Now coming to the introduction, the infertility is a very rampant one. Nowadays, all of us know that it has increased over leaps and bounds, and currently it's around 150 million people in the world today are suffering from infertility, if you call it as a disease. It's a complex state. Why I'm saying it's a complex state is because in addition to the medical causes, it's not only the medical problem somewhere in the couple, there are also other factors that are involved, like the implications of involuntary childlessness is that it's involuntary. A person suffers from infertility will face other many complex issues which span biological, psychological, social, and ethical domains. There is interplay between several of these factors which I have mentioned. It is not only that much, it also affects other factors, like it tends to provoke many issues of cultural factors because it matters a lot in their society. The spiritual factors, the moral, and the very ethical nature for the would-be parent. Discussion of these issues in a counseling context, it should be the counseling part one should concentrate on, is often very beneficial for patients. However, in addition to the necessary medical procedures and advances in infertility options, all of us as IVF specialists concentrate on the medical procedures, the investigations, the drugs, the follicles have not come up, these kind of things. But we don't concentrate on what is happening in her mind behind all this. The clinician should also focus on the patient's psychosocial and emotional needs by providing proper counseling. Few situations in life are so challenging, and one of them is infertility. It is equally demanding and very stressful to the couple. Those who suffer know. Infertility is a medical condition that affects every part of the person or the couple's life. As I said, it prevails in many of their arena, their domains. It comes in their mind in every moment of their life. Patients often express a sense of loss of control over their lives, themselves itself, when the positive treatment outcomes do not happen. The medical intervention, multiple diagnostic procedures, and clinic visits can compound the anxiety. They have to come repeatedly to us, not for fun. By compulsion, they have to come. Though they are not happy to come, they are supposed to come, they're compelled to come for some patients. It may challenge the way in which they feel about themselves. Their relationship may be spoiled between the couple, relationship with the family, their profession. It may come in the way of their profession. They may not get holiday or loss of pay, and their outlook on life ultimately. Their personality, life experiences, and coping style all play a part in how they feel and react. In addition to the support of family, friends, and medical providers like us, they may benefit from the assistance of professional counseling services. Sometimes that part may be replaced by us only. Infertile patients have had to go through tremendous efforts in order to have a child. They might have tried a lot. The journey might have been so tedious. The pregnancy represents an enormous investment of time, emotions, energy drain, and definitely lot of money goes there. During the treatment, patients focus on becoming pregnant. That is their ultimate dream and ultimate goal. Patients have many fantasies about how extremely happy they would be once pregnant. They would probably fantasize the fetal movements and certain things like that happening in them. However, when pregnant, they have to deal with the possibility of complications, and the risk of losing the pregnancy is there lurking in their mind all the time. This is especially problematic if they already have experience with one previous reproductive loss. Clinical experience shows that anxiety and stress are increased during pregnancy compared to those who have conceived on their own if they have undergone the infertility treatment. Some may develop an exaggerated worry about each normal physical event. For any other normal pregnant woman, it is a very normal event. For the doctor also, they think it is so silly. But for this woman who has conceived on infertility treatment, the smallest trivial thing becomes a very big issue in her mind. Example, if there is fetal movement in the morning and if it is not in the afternoon, she gives a call or she comes running to the hospital, doctor, I can't feel the fetal movement. Such things do happen. Some pregnant women do not feel extremely happy, paradoxically, about their pregnancy as they feel they should. That is what she was dreaming for all these days. But once she has attained, somehow she is not happy because she is so scared of the future events till the baby is in hand. You look very tense and anxious. Can I help you? This is what we are supposed to say. Infertility counseling is a way for patients to understand how they feel about infertility and the treatment procedure. It gives them a better understanding of choices they make and helps them accommodate their feelings. It's a highly recommended step, highly recommended in the process seeking IVF. Before IVF treatment, counseling is very essential. Before we induct her into our cycles, counseling is very essential. Both the partners should be clearly explained the procedure, what we are going to do, and they're advised to lead a normal, healthy life during the treatment. This is very essential. They're advised to avoid unnecessary stress, which is not required during the treatment procedure. We have to allay her fear during this counseling. The aims of counseling are to explore understand and resolve issues arising from infertility and its treatment, and to clarify the ways of dealing with the problem more effectively, so that she is cooperative with us and she helps and takes the treatment more efficiently. The counseling process should consider the needs of the patient and any other person who might be affected by the treatment process and decisions that they make. It should be tailor-made. It is not a typical stereotyped process which we follow to all the patients together. It is individualized to each patient or each couple. Counseling is a kind of therapy rather to both psych and soma, which include the process of assisting the person's need by guiding them and providing them the ways to resolve the problems. That is what ultimately required, which may be social, personal, psychological, and any other. There is a danger that emotional impact of infertility is neglected. It happens most of the times, as all of you know, and that the issue is reduced to a biological or medical one. As I told previously, it is just considered, she is considered as an infertile patient. That's all. Don't think inside the box, think outside. The counseling service plays a major complementary role in providing holistic patient-centered care by multidisciplinary staff in the fertility clinics. It is many people who are involved in caring for her treatment. Caring for the emotional needs of the couple demands continuity. It is not a one-point program. It's not a one-visit program. It should not be treated as a single event. The issues which confront the physician may also be experienced by the entire team involved in the care of the infertile patient and couple. Various professional groups are involved in the medical diagnosis and therapy, each with a special task according to their skill. The OT technician, when we do the hysteroscopy, will do his part. The HSG radiologist will do his part. Counselor will do his part. And the nurse will take care of the injection, the dosage, and the timing. The medical side is made up of physicians, embryologists, nurses, our andrology technicians, and andrologist, whereas the psychological side is composed of psychosocially oriented members such as counselors, even sometimes nurses, psychologists, psychotherapists, and psychiatrists. What are the important points in counseling? All the slides which I am telling is not new. It is just all compiled and put together so that I drive the message home. Confidentiality is the primary and basic rule of counseling. It's a confidentiality is the key word, and it is mandatory to follow to all of us. A counselor should neither become judgmental nor should get emotionally charged with the client. When we can't express our sorrow in front of them. We can help them, we can counsel them. The counselor should be as neutral as possible towards the motivation to continue or abandon. She or the couple have the freedom to either continue or abandon the medical treatment. It is our duty to put things in front of them, and it is for them to select out of that. And we should never impose our decision on the client. The aim of counseling is to enable the client to make their own choices, reach their decisions, and act accordingly. It's our duty to make them understand, make them convince, and leave it at that point. They should use their own judgment and make their own decision. A counselor should always be empathetic and not sympathetic. Patients should be given the feeling that they have resolved their infertility to the best of their ability. They have tried to the last point, regardless of the point at which they ceased medical treatment. They'll be more happy because they get self-satisfaction. They have tried everything and they have left no stone unturned. Not to disclose the matter to any other. These are another key points of counseling. Not to disclose the matter to anybody else. As I said, the key word is keep it to them only. But still, sometimes they want us, they insist that we have to express and inform to their mother or mother-in-law, and then only we are supposed to inform the near circle. Be careful not to assign sole problem to one partner. Example, if the husband is azoospermic, we should not say that it is the only problem. The wife also should be evaluated, and she also may be having problem. So look at both the partners and come to a conclusion who has the problem and where the problem is. It may not be a sole problem. Not to use such words which develop discordance between the partners. The marital discordance, marital harmony should not be disturbed because of our counseling. We should not spoil the situation. If the husband is azoospermic, we can't say that your infertility is solely because of him. We should say that he is azoospermic, agreed, but there are certain more things which we can do and we can find out. And also we should say that there may be certain things we have to evaluate in the wife. So the marital discordance should not be broken because of us. Tell them to read about their problem when they come. Let them get enlightened. Let them get educated. Accumulate more points and knowledge when they come to us, so that the message can be driven home easily. Tell them to spend time together, like daily chores, exercise, or recreational activities to improve the marital harmony. Counselor or the nurse or ourselves sometimes are there to make them relaxed. We have to explain and counsel them. No rude behavior from any of us. No undue waiting from the patient side. They should get proper appointments and come, and we should see them on time. Quick solution to their queries and their problems to be addressed is very essential. From the physician's first meeting with the patient or the couple, an atmosphere should be created that nurtures a trusting physician-patient bondage. That relationship should develop. Such an atmosphere is one based on openness and mutual respect. Couples should be given the opportunity to ask questions. They should be encouraged to open up. They should be encouraged to voice their own ideas about their treatment options. Who knows, they may be having better ideas in their mind. They might have gone through the books or the social media, or somebody in the family might have taken treatment. So they are encouraged to ask more questions and express their opinion. Information about their health issues can be given in person or in booklets, videos. So we have to part knowledge with them. We have to give them more education about their problem. Informed consent. All information shared with the patient and family need to be documented in the local language and signed by the couple and one witness from their family. Documentation is very important. In case the couple is illiterate, as it happens sometimes when they come from the rural areas, ask for a family member who can read and write and sign the documentation on their behalf. Discussion should be as per laws of the land. Counselor. While an agreed set of criteria for who should counsel has yet to emerge, there is no such role as a counselor with set criteria that this person only can be a counselor. Such a thing does not exist. At the minimum, counselors should have received training in one of the mental health professions like psychology, social work, counseling, etc., as well as training in the medical aspect of reproduction. It is the counseling plus some knowledge on reproduction per se. All staff can and should provide patient-centered care, but only professionally trained individuals can provide better counseling. Of course, we, our staff, our nurses, everybody should give patient-centered care, but the counseling is little bit more. What are the drawbacks of counselor? We should not think that we have appointed a counselor, he or she will do their job and my job is finished. I'm there just to stimulate, do scan and do ovum pickup. No. However, referral to a counselor may cause sometimes problems to some patients. They may interpret referral as rejection on the part of the primary physician. The doctor doesn't want to see me anymore. I wanted to explain all my problems to her, but she has resented herself and she has handed over the job to someone else. The patient should not feel that she is rejected. Such a referral may hurt her feelings, and especially if counselor is not intelligent enough, incapable of conveying the right message, because there are many intricate factors, intricate matters that are involved here, especially when the donor programs are involved. So when they are incapable or when they are not able to understand the patient's feelings. More than anything, if the medical treatment has been unsuccessful, definitely the patients will not be happy, and on top of that, if the counselor is not good, the patients will definitely not be so happy to be counseled by such a person. Because of this, involvement of good counselors should always be integrated into the patient care from first consultation itself. She should be part of the program right from the beginning, and she or he should be presented to the couples in a positive light. About 1/3 of all the couples report sexual dysfunction during the diagnostic investigation and treatment right in the beginning. Since couples often have difficulties discussing matters of sexuality, they are not so happy to discuss in front of many people. It's important that consultations take place in an atmosphere that makes it easier for the couples. It makes conducive for the couples to talk about such intimate matters. Physicians should therefore be prepared to address the problems of sexuality both in the diagnosis. Sometimes it comes at the time of diagnosis itself, like masturbation for the semen sample, or retrograde ejaculation, or the erection disorders, and sometimes in the treatment also, like time scheduled sex. When we need the semen sample, masturbation may not be possible, so these kind of issues may arise. Sexual problems causing infertility. Sometimes the sexual problems per se cause infertility. They are the primary problems, and surprisingly, they do not have any other big things or the big reasons of infertility what we think of. For a small percentage of infertile patients, the sexual problems are the primary cause of infertility. Because of the sexual problems, they are infertile, and they can be masquerading as cases of infertility, like infrequent intercourse, vaginismus, dyspareunia, lack of sexual desire itself, the basic problem in many of the people nowadays, because they don't have time or they don't have desire. ED, erectile dysfunctions. These sexual problems may be of organic or sometimes psychological origin because of the job stress or some other psychological issues. Sometimes the sexual problems are secondary to infertility, opposite of the previous slide. Like for a large percentage of patients, infertility may have a various repercussions on the sexual functioning. Because they are infertile, they are not happy with the sex, like lack of sexual desire or the orgasmic dysfunctions, etc. Problems of the IVF treatment. It is sometimes hard to deal with other people. It is so hard for them to deal with other people, especially when they go for a social gathering. It's very difficult when other people announce their pregnancy, maybe a sister or niece or whoever, young, especially when they're younger to them, who are married for a shorter period, when they announce their pregnancy, the happy news, having a baby around, or just seeing the people enjoying family life. It is very difficult for them to digest. Infertility treatment is prolonged, time consuming, painful, stressful, frustrating, lot of anxiety issues, and definitely so expensive, and ultimately may not yield a positive result. Back to square one. So psychological burden and physical burden. So they face both. Problems faced by the couple. Patients do not understand the results or misunderstand certain parts of the result. When the counseling happens, these are the things sometimes which they may not express. These are the problems they face, they may or may not express. Like they don't understand what we are saying, the result, because we talk big terms, they don't understand. Or sometimes they misunderstand what we are speaking. When we say hysteroscopy, they don't know what is hysteroscopy. We should say, I'm checking inside of your uterus. I'm checking inside of the uterine cavity. We should draw a diagram and show them and make them understand. The language used by the team is not appropriate sometimes. We don't do it purposely, but when we are talking in our own language, it may be very difficult. There may be too many professional words. The medical jargon is very unfamiliar for them. The information giving about the results lacks empathy sometimes. We just give the report. Your beta HCG is less than 50. Beta HCG is just 5. Beta HCG is not doubling. The sac is not seen. The fetal heart is not seen. We may just tell her so plainly, but that is a very, very difficult for a difficult thing for her to digest. It is so traumatizing for them to receive the negative results, and it is very difficult for the couple to cope up with such a problem. In case of unexplained infertility, the problem is compounded because we say that everything is fine, everything is normal, the sperm count is normal, you are ovulating, your tubes are fine, and your endometrium is doing fine. The problem is they don't understand. They ask, then where is the problem? Why am I suffering from infertility? It's very difficult to cope with that kind of uncertainty. It's normal that couple desire for a child, but if this desire remains unfulfilled, what are all the problems? How can the psychological expressions be? They can be from anything from stress to loss of job, loss of pay, bodily symptoms, and it may be a permanent depression, the secondary depression in some people, where they need a psychiatric assessment. You may be surprised, but there are certain people who may need a psychiatric assessment. About 40% of people experience loss of libido after IVF failure, which is a large contribution. Women report significantly greater infertility related issues, of course, natural, greater infertility self-blame, self-esteem, and avoidance of friends. Women are not like men. Men take it in a better way, but women take it so personally, so it affects them to a very great extent. It has been, it's been documented that unsuccessful treatment raises women's level of negative emotions, anxiety, depression, and whatnot. It is considered almost completely a woman's problem in certain classes. It is a very difficult situation for her to digest. Other than the infertility, other than rest of the problems, she is thought as the culprit. That is a very difficult problem, and this can lead to the feeling of shame in women. They may not come out in public. What are the things to do during consultation and counseling? What we are supposed to do? We have to spend enough time with the couple. We have to call the couple, not the woman alone. Read their psychology, develop relationship, solve their doubts, encourage them to ask doubts, listen carefully, understand and empathize. All this needs lot of time and patience. Understand their family problem, financial, because infertility is not just a medical problem. Explain about the subject, investigation, each investigation what we are doing, and why we have what we have arrived at, why we are doing, and different treatment options available. Are you a candidate for IUI, or should I take you directly for IVF? Are you for a donor program? May need separate interview also in future, and one or two settings according to me will not suffice. During consultation, observe and assess. Even before talking or while talking, we can silently observe and assess certain things like their family cordiality, how husband and wife are, how mother and daughter are, their financial problems, their education level, the way they are talking, their IQ, their emotional quotient, know their lifestyle and culture, what culture they are from, what background they are from, because there are so many taboos. Readiness to take treatment, are they willing to take treatment? The languages they can understand, because if you don't ask, if they are silent, and after talking for a long time you understand that they haven't understood anything what you have told, it's all waste what you have done. There are different models for psychological counseling, as all of you know, Devereux and Hammerman model and Cooper-Hilbert model. I'm not going to detail of all this because I've got many slides, and ultimately we are talking of something different and not per se about these models. But the gist of that is both help in decision making, stress management, promote the acceptance, promote responsibility, and ultimately we have to plan what we are supposed to do for this couple. There are different types of counseling also. The information counseling is just as the name themselves express. It is talking to the patient and give lot of information about each thing, the diagnosis, her investigations, the treatment, what we have arrived at, etc. The implication counseling, in the sense what is going to happen secondary to this. What does this imply? What does azoospermia imply? What does poor ovarian reserve imply? Are they supposed to go for donor program? So these got a certain implications we are going to express. Support counseling is more of emotional support, and they crying on our shoulders like. The therapeutic counseling is we are going to explain each time what we are going to do. Why I have given you the HMG injection, when I am going to give you trigger, why I am going to give you trigger, what kind of trigger I am going to give, what does ovum pickup mean, etc., etc. IVF events that add to the psychological burden. There may be a negative outcome. This may be a pregnancy loss. Pregnancy has happened but did not continue. The next step, then waiting to know at each stage itself is very difficult for her to manage. To cope up with it is very difficult. Like each time we say so many follicles have come, but how many eggs have come? Out of that, how many are quality eggs? Have they fertilized? Are there, what is the quality of egg? Have you frozen? When are you going to do transfer? So many things. Each step is a lot of stress to her till the baby is in her hand. IVF events that add to physical burden, not only the psychological, it adds to physical burden also, because she has to come repeatedly for a lot of investigations to us, especially when the male is not able to give the semen sample, even by masturbation. That's a very difficult situation for him. Every time she has to receive injections, the ovum retrieval, embryo transfer, all the treatment per se itself causes a lot of physical burden. What are the benefits of counseling? Why should we counsel the patient? Why can't we give her just the treatment, send and talk at the end of our treatment is over, like your beta HCG is negative or beta HCG is positive? No, that's not all. It would help them to tackle the frustrations and their depression. It improves their self-confidence, very, very important. Couple understands the events, they understand each level what we are doing. So they will be definitely, there is better compliance. They'll be more friendly and they'll cooperate with us for all the steps what we are taking. They take prescribed medicines, they take when we expect them to take. They take the proper dose, the time, the duration, everything. And they follow our instructions so properly about diet and exercise. We tell her take this type of food. We tell her do exercise, lose your 5% of body weight, etc. They come for regular visits. They report the complication earlier. Example, the OHSs. We recognize the OHSs early stage itself. She says, I'm little oliguric, I'm putting on little weight, I feel little bloated. So these kind of things, they'll inform us much earlier. It builds up a healthy relationship between the service provider and the recipient. They feel they're involved in decision making and they're happy because they're involved and they are the active participants than not knowing what is happening around. Lesser probabilities of medico-legal issues, which is very, very important and very vital in the present era. Patients who require some form of genetic counseling as part of their fertility treatment, like PGD. They may wish to have the PGD for their own embryos with a bad experience in the past, or they may like to screen the donated embryos also. So ultimately, what is the benefit of counseling? It is that we get near expected positive response. Ishre says, not only the previous slide what I mentioned, it advances itself and tells some more points. Counseling facilitates the decision making regarding continuation or termination of treatment. It's not just taking treatment continuously for months together. They should know where to stop, or are they supposed to continue the treatment, so they can make decision for themselves, because it involves a lot of time and money. It informs the individuals and couples regarding psychological, social, and legal implications of the donor treatment. Very much, they should very much know about this part. It offers support to help manage the psychological distress of infertility, like issues of acceptance and grief before, during, or after treatment, very important factor. It facilitates the discussion of alternative to parenthood. Parenthood is not the ultimate. So they may think of other things like adoption or living a fulfilling life without children. Having children is not ultimate. They can even enjoy their life without children. Quality of life is more important. It solves the sexual, marital, and other interpersonal problems also. Couples select the IVF. So why do they go to IVF center? What are the points or what are the factors they keep in their mind when they come to a particular IVF center? The name, qualification, and popularity of the doctor and center. They would have heard the doctor's name or doctor's center through somebody. Their own patient might have come to the hospital and got treatment, and word of mouth. Experience of the doctor, the comfort level, the time convenience. Some doctors may not be available in the evening. The woman goes to work and she'll be able to come to the hospital. She'll be free only in the evening hours. So the time doesn't coordinate between the two. So she's not able to come. Proximity of her living place to the clinic. The cost of treatment. They check the cost between the centers. They ask the patients who conceived with IVF, how much did it cost to you per cycle? The success rate of the center, a referral and word of mouth. The quality of service, which includes the primary part of quality of service, is counseling. Mandatory counseling service sessions. We are supposed to counsel the woman or the couple each and every time, but these four are very mandatory. We cannot skip on these counseling sessions. Pre-IVF, very necessary. Why I'm taking you to the IVF? Soon after the ovum pickup, how many eggs I got, how many M2s were there, when can you go home, am I going to do the fresh transfer, in which case I have to start you on progesterone, am I taking you for the FET, certain things I have to tell soon after the ovum pickup. Then post embryo transfer, I'm supposed to give her the luteal phase support. Then I'm supposed to tell her how far she's supposed to take rest. She has the doubt whether she can go to office or be at home. Can she be ambulatory? When she has to confirm whether she's pregnant, whether your treatment was successful, so many things. Definitely after their pregnancy test, when you do the beta HCG, you have to disclose what happened to the beta HCG report. So these sessions are very, very mandatory. Reasons for discontinuation. Some women or some couple do continue for some time. They come for certain visits and then they stop coming. Why? Unsuccessful treatment or poor result. Tried for 4 cycles, 5 cycles, they did not conceive. They are very unhappy, whatever is the reason. Not comfortable with the doctor or the clinic. They are not informed enough. Somehow they are not happy with the doctor or the clinic. The pregnancy loss, they conceived luckily, but unfortunately they lost that pregnancy. Scarcity of time. Some people really do not have time. The work schedule is so busy that they think that infertility is a secondary issue to them. The distance to the hospital. They can't come after finishing their work, or husband is not there to accompany them, which is ultimately it's very difficult for them to come to the clinic. The spoiled family relationship. She's not in good terms with her mother-in-law or husband. There's no cooperation at home, so there's a lot of stress in the family. There is no harmony in the family, so she can't come to the hospital because that is a primary issue, and infertility takes a backseat. Loss of job or discontinuing job, which adds to financial burden. Again, she may not be able to cope up with this factor. Majority lose hope after one IVF failure. When they undergo this IVF, they'll be very happy, hoping for the best. But when we declare the beta HCG result and it is negative, they really lose hope. Those who repeat IVF treatment is around 40%, and those who do third IVF are very, very less. According to one statistics, there are many studies, but this is one statistics, I could put it like this. 30% of the infertile couple never sought medical treatment. They just came for a visit. They spoke to the doctor. Little counseling was over. After that, they never turned up. Even for the investigation, not even the very primary investigation, They never turned up. 20% discontinued before the first cycle of treatment itself. The investigation happened, we did HSG or we did hysteroscopy or we did the hormone studies, and at the end of that they disappeared. 20% discontinued before the first 3 months of treatment itself. We started the treatment, but before we do something proper treatment, they disappeared. 30% discontinued when we advised IVF. They don't want to undergo IVF for whatever reason. Most of them think that, especially when the reports are normal, they think everything is fine. Why can't I wait for some more time? At this time, it's our duty to tell them that age is an important factor. As you keep growing old, your fertility factor reduces, and one day if you come to us or anybody else you go, you may not be able to conceive as easy as it is happening now. The clock, biological clock, keeps ticking. 40% drop out after one IVF, as I told in my previous slide. How should we improve the compliance? What are all the tricks we can do to improve the compliance? Counseling to reduce the mental stress, counseling, and counseling. They'll be more cooperative and compliant if they understand what is happening. We should reduce the cost. HMG injections, certain things, unnecessary investigations, repeated E2, repeated P4 can reduce the cost when we are judicial about it. Reduce the visits. About 4 to 5 visits pre-ovum pickup and 2 visits pre-FET to know the endometrial thickness are usually sufficient. Explain by the videos and diagrams. They should get the certain education material so that they can understand what is happening. Reduce the blood tests. Improve the results. Available doctor or nurse, one point of contact should be available on telephone to her. Take help of digital media. YouTube videos are very educating nowadays to all of them. Tell them to watch your success stories when the patient becomes beta HCG positive or a fetal heart appears, your academic achievements, the procedures, each procedure. What is ovum pickup? If she comes prepared, the day she comes for ovum pickup, has she seen the YouTube videos, she knows what is ovum pickup, or she has seen a very nice video of the embryo transfer, and then she comes. It is very easy for us to explain or to make her understand, and she can also view the other videos about the ART in general. Give the digital links of the concerned matter and informative website addresses. So many websites describe about the infertility in detail, the ART treatment in general. Arrangement for the couple to watch the videos of IUI, IVF, etc. in a separate room in the hospital itself, not only in their house, even before giving the sample, the semen sample. If they watch a video, what they are supposed to do, the instructions, sitting in the separate room will educate them, and it will be easy for us to drive message home. What are the special needs during counseling? All patients or the couple may not be, it may not be enough with what facilities we have. Sometimes certain special facilities are needed, like translators may be needed, or the interpreters when their language is totally different, we don't understand, or they do. The visual aids may be necessary sometimes when they are visually challenged people. The visa issues, especially when they have come from other countries. The foreign nationals, not only the visa issues, they have other problems also, like accommodation, their food and currency, and so many other things, like their birth certificate, their identity card, so many things. What are the stages of counseling? The pre-treatment, during treatment, and post-treatment. I have divided it to make it simple. The post-treatment includes, it may be a success case or it may be a case of failure. Either way, we are supposed to give them an elaborate description about what happened in counseling. Coming to the pre-treatment. Outline an individualized plan for that patient with your plans. Before she comes to IVF, we should make an outline and we should make plans what we are going to explain to her, what is our decision, what we are going to do for her, when are we going to do those kind of things. Like day 2, you are supposed to give the hormone test. Then you are supposed to undergo yes or no hysteroscopy. This is the day I'm going to do your ovum pickup. So certain timelines. Counseling is dependent upon the legal, ethical, and cultural background of that particular country. Adapt your plans as per these backgrounds. These guidelines are not strict rules or fixed regulations. We should have forms ready to document everything. Prepare to share the education material with the couple, whatever we have. A pre-treatment also includes explain about the possible complications and the warning signs, as I was telling about the OHSS previously. Explain the importance and advantages of the lifestyle, what diet you're supposed to take, why you're supposed to exercise. Explain about the cost in split figures. Each step we should explain. Ovum pickup is so much. Your fresh transfer is so much. If it comes to a frozen transfer, you're supposed to pay so much extra, and allow installment payments also. Some combination entities like STD and tubal problems or obesity and anovulation, some certain things should be explained to the couple, because they will know if this is there, what is going to happen. If I smoke, my sperm count is going to get reduced. If I'm obese, I may not ovulate regularly, etc. Relatively increased incidence of POR, that is poor ovarian reserve, is known in Indian women compared to Westerners. Explain about FET and third-party reproduction in certain cases when it is required. During treatment, what we are supposed to do? Reduce the stress and anxiety levels. Help the patients to deal with their feelings of guilt, restore feeling of self-efficacy in order to help them to feel in control over their situation. Reassure the patients about the impact of treatment on the health of their baby without underestimating the chance of having a baby with a congenital or genetic problem. The baby may have, we should not underestimate the problem. In the sense, the baby can have a congenital or genetic problem also. The possibility should be explained to them. Also help them to deal with their fear. It should not be an unnecessary fear that every IVF baby will have a congenital or a genetic abnormality. Information to be shared while counseling are the basis, the limitation and outcome of treatment. What is the basis of my treatment? Why I am doing this? What are the limitations of this treatment? And what is going to happen? Risks or side effects of the procedure. The option of cancellation also should be explained. Sometimes if they are PCOS patient, the follicles may be too many and we may cancel the cycle, or change in the plan may happen. Like we are planned for IUI and we are taking her for IVF in the same cycle, and the follicles have come too many. The transparency in the charges, this is a very important fact. We should be very transparent in our charges. As we have quoted in the very beginning, we should stick to our words, and cost with the breakup should be given and no hidden cost. We should not explain another adding charge each time, because they will definitely lose hope on us. Results have to be conveyed each time. What happened to the blood test? What happened to the investigation report? What happened when I did the ultrasound scan? How many follicles have come? We need to make them aware that child after attaining age of 18 has the right to know about its identity. Explain about the ovulation days and dates for timed intercourse, because when we are giving treatment, it's not that they should not try on their own. Counseling regarding improper sexual act, sometimes it happens, like erection disorders. Explain about the method, importance and result of each test what we are doing. This is a very busy slide. Please excuse me for putting so many things in this slide, but I thought all of them should be together. These are the questions we have to ask the couple. Some general questions which all of us ask, like what treatment you have taken before? Have you taken treatment before? What kind of treatment? Were you happy? What was the result? Since how long you have been trying? So many such things. There are some problems in the sexual problems also, these questions also we are supposed to ask. And how do you view the alternatives? Is it the primary treatment, the IVF or IUI, and the self treatment only you want, or are you ready to go beyond this horizon? Are you ready for adoption? Are you happy if you are childless? So certain things we are supposed to inquire and find out how and where she stands. Counsel during the treatment. Counsel if there is any change in treatment plan, drug or dosage which may happen, and each time when we see her. Alert about OHSs because it is a very medico-legal problem. Cancellation due to any reason, if it happens, we should explain. We have taken her for the fresh transfer. We are not happy with the endometrium, or there is fluid in the endometrial cavity. We might have cancelled or postponed the cycle. We have taken her for FET, but the endometrium has never come. We might have postponed it to the next month. So we have cancelled in this month. So these are the things we are supposed to explain. The freezing options are very much to be told, because one is this cost, money. The second thing, it is a social problem also, because she has to keep herself free during those days, and she may be thinking that she's for the fresh transfer, and she should not be told all of a sudden that we are not taking you. The option should be told to her. Number of embryos to be transferred, how many embryos we are going to transfer, and after the embryo transfer, how many embryos we have transferred. The day to transfer, 3 transfer, or is it a blasto transfer? These are all the information we are supposed to tell her. Counseling should also deal with the side effects or the problems of ART. All the problems which all of us encounter, like it's maybe during the pickup or the embryo transfer, the problems of OHSs, the multiple births. Some people may need fetal reduction if we have transferred 3 embryos and all 3 have taken up. The chance of miscarriage, the ectopic pregnancies, maybe sometimes iatrogenic, the birth defects, the pregnancy risk due to the high maternal age because they would have come after the age of 30 to us, the preterm labor, low birth weight babies, and even the remote chance of ovarian cancer. The consent forms, information leaflet, and handout should be in English and the local language. Hospital staff should give reminder calls or some kind of message for the scan and the injection. Even the time of injection is very important. If they go to some other nearby doctors for injection, we should hand over a form to her, example in an Excel sheet, where it gives the clear instruction about the type of injection, what kind of injection, how it should be given, the route of injection, what is the dose, when to be given, what time it has to be given. So all the details should be there. Also, preferably to take the injection in our own center, because our nurse is trained. She has the knowledge about what kind of injection, when to give, and more than that, the cold storage should be maintained. If they take injection outside, the temperature might have varied. The outside, the drug may be from a different company, maybe from a different batch. So many problems. Use the drug with the pre-filled syringe, and subcutaneous injection is preferred. Instruction for self-administration is best. If they train themselves, they don't even have to go to the doctor. The husband or mother can also give injection to the patient. Tell them to apply the ice packs on the injection site. Clear, detailed instruction should be given how to come for the ovum pickup. Come 2 hours early. Come kneel orally. Bring your husband. The consent. So many things we have to explain. And the embryo transfer also, and the post-procedure instructions, how they are supposed to be at home after the embryo transfer. Also, how many follicles have come, how many eggs we have retrieved, and further on whatever step happens in the IVF cycle, the different IVF events. Every patient should have one point contact, that is any sister or a counselor or some person in the hospital, and that person should answer all the queries patiently and in an understandable way, either through phone, SMS, email, or WhatsApp, whatever may be. Give the actual and true success rate to the patient, and don't give a hyped picture. Unexpected negative result, if we have explained everything that it is a very bright case, very nice case, you are going to conceive and ultimately give a negative result, that is the number one reason for litigation, because patient becomes very utterly disappointed. Tell about the flip side of investigation, the different facet of the investigation and treatment. Each visit, we are supposed to explain about the status, progress, and next course of action. Discuss about the different options and their choice of treatment. It is for IUI, IVF, fresh transfer, you are for frozen transfer, you are for donor program, so many things. Tell about the complications in brief, like OHSS or multiple pregnancy in PCOS, or the negative result in POR woman, that is a poor ovarian reserve. Inform them about the importance of repeat cycle, because many of them may think that one cycle done and that is enough, I will get pregnant. No, you have to tell them in prior itself that sometimes it may need that 3 to 4 cycles are required. First cycle, it may be the understanding her. The first cycle may be the preparation cycle. And duration of the treatment may sometimes even last for a year, including repeat FET cycles. What are the miscellaneous issues? All of us know about their different lifestyles, infrequent and inappropriate coital days we have to explain, because many people are unaware of this issue. The job related, the thermal plants, etc. They may be working there. The tight undergarments, the stress, lack of sleep, diet, so many things. What else are we supposed to do during counseling? Sensitize even not only the patients, the first circle, the second circle, or even the general public, the general practitioners, and even the other patients regarding IVF. What I'm telling here is that the people or the public think that IVF, when they go to the IVF doctor, whether we are the candidate for IVF or not, they push us to IVF. No, it's not like that. Tell them that only the eligible candidates will be taken to IVF. Tell them that success of IVF is better than success sitting at home or IUI. Tell them that if you are more aged, you may not be able to conceive. So sensitize them what are the advantages of IVF. One bird in hand is worth two in a bush. Majority of pregnancies happen spontaneously within 1 year of married life. Tell them that if everything was fine, you are supposed to get pregnant by 1 year of unprotected intercourse if you follow ovulation. If it is 2 years, 3 years, 4 years, why pregnancy has not happened? Make them understand. They need physician's help after 1 year of not using any kind of contraception, or earlier maybe if their reports are abnormal, like severe oligoasthenospermia or tubes are blocked, etc. When and who are the candidates for IUI? We have to explain and make them aware. When and who are the candidates for IVF? We should tell them that you can't go for IUI, or you can't postpone your treatment. You are the candidate for IVF. We have to clear certain myths about IVF. IVF comes with bundle of myths. IVF gives abnormal babies. IVF babies are not natural babies. They're manufactured in the lab. IVF babies do not carry the parent genetic material. To a certain extent, this is true in donor programs, but not all. IVF injection cause health issues to the mother and offspring in the long run. They put on weight. They get menstrual irregularities. This is the myth. IVF woman should quit the job and relax at home. No, not necessary, especially till you are ovum pickup, or even few days after your embryo transfer, you can resume your job. It is simply unaffordable. No, it is not. IVF woman needs 100% bed rest, pre and post ovum pickup, FET, and throughout the procedure, she is supposed to not get out of her bed. IVF pregnancies definitely abort. They don't continue because they are not natural pregnancies. IVF babies have congenital anomalies. Many of them have congenital anomalies or mental retardation. No. IVF success is almost nil. Again, no. Post-treatment, what are we supposed to do? About the rest and diet, we have to counsel her. The sexual relationship, definitely okay after, say, around 10 to 12 weeks of pregnancy. Drugs and their side effects, are they safe? Are they going to give side effects? What drugs she can take on her own? about future antenatal care and management. When is she supposed to come for scan? When is the NT scan? When are further scans? The pregnancy loss or the complications? What are the complications that can happen about the GDM, PIH, multiple pregnancy, so many other pregnancy issues? Counseling to allay the fears of miscarriage, because any patient or the woman who has conceived on IVF has a very strong fear of miscarriage, and she also is not mentally adjusted for future parenting. If IVF treatment was not successful, counsel and make them understand why it happened. It's not your fault always. We need not be guilty. We have to tell them what happened and make them understand and convince them. Be one in their grief and loss, of course. The couple should be the satisfied one when they leave your center, come what may. You should explain and make them understand that these are the things happen. It is not the fault from your side, neither from my side. We did our best. So one satisfied patient will definitely bring few more. Sometimes it may even be a negative result. In spite of that, we are surprised to see them bring another patient to us because they are so much convinced with our treatment. How to break the news of negative beta HCG? Very difficult situation to explain. Till they come to the IVF treatment, they are very happy with the hope that they will get pregnant. But now that hope is shattered. How to face these people? It's very difficult to face the couple. Prior counseling about IVF journey of the present cycle, what happened all these days, like eggs retrieved, how many eggs came, how many fertilization happened, how many were P and stayed, what was the quality of embryos, so many things. If we keep explaining throughout the journey, it will be easier for us because they are mentally prepared. It will make our job much better. Give them emotional support, of course. Involve her close relatives in the loop or only husband, however they wish to do. Discuss with them in detail about what happened. Why did you not conceive? Discuss about the future plans. What do I have in store for you? What I am going to do? This is not the end of the journey. This is not the end of the road. Let us try more. Let us do something different for you. So encourage them. Explain and tell them to get information on newer technologies. Meanwhile, at home, let them give their inputs. What else can be done? Study the case again, take their case file, start from the first page and read again where what went wrong or nothing went wrong. Rethink whether anything went wrong from the clinical side or the embryologist side. Were the drugs fine? Was the cold chain maintained? Was the embryology lab quite fine? Was the QC maintained of the lab? Change the events or add newer things. Like sometimes we may have to change the type of stimulation. We have given HMG plus FSH. This time you may have to give just pure FSH. You may have to use only recombinant. You might have given only the HCG as a trigger. Now you may have to plan the dual trigger. The freeze all sometimes and transfer at a better when the endometrium is more conducive. Testosterone gel and growth hormone in poor ovarian reserve patient. GCFS injection to improve the endometrium. Endometrial scratch, mock ET. Think. Cornerstones of success. Selecting right protocol for the right patient. The counseling so that they carry out our orders and cooperate with us and are in a better term when they come next time to us. Enhance the oocyte, sperm quality and thereby the embryo quality, of course. Improving the endometrial receptivity. The soil should be better along with the seed. Optimizing the embryo transfer timings. Ensuring good quality lab procedures. Lab QA and QC at intervals should be revised. Revising and improvising on the protocols, drugs, and techniques periodically. These are all things that are important to improve our success from case to case. Little bit away from what I spoke so far. The immigrant couples. Immigrant couples may have additional communication or language problems to add to our problems, which may compound the problem of understanding the diagnostic and therapeutic information. They're not able to understand what I'm doing. It is therefore essential that information and consent forms are available and preferably can be given in the patient's mother tongue, any language which they are very familiar in. Providing the fertility clinics with the network of translators or interpreters who should be either professional translators or interpreters or members of our team itself who are native speakers with the written and supplementary visual material also helpful. The native speakers, I may not know Telugu, and my staff, my nurse knows Telugu. So let her be an interpreter for that patient. And also the supplementary and visual materials in their language. Understanding the meaning of infertility in the cultural setting and encouraging the patients to talk about the cultural background of infertility. Of course, there are many cultural issues in infertility. Making the diagnosis and therapy both accessible, being respectful of the patient's socio-cultural background. Providing female gynecologists and female counselors. Some patients are very particular. For some patients for whom a male gynecologist would not be a pleasing one, they don't allow male to check them. In some cultures, question of sexuality cannot be discussed. It is a taboo that cannot be discussed between men and women, that too with the doctor or in public. Patients should be asked whether they would prefer a male or a female counselor, not only the gynecologist, to discuss their issues. Masturbation is not socially acceptable in some cultures. This must be taken into account when dealing with difficulties regarding producing the semen sample when we need during ICSI or IVF. The production and availability of information brochures, videos, or the internet in the different languages is also important. Videos and pictures are of a major importance as 10 to 20% of the patients are illiterate. If you give some written handouts, they may not be able to read. So videos and pictures are more information driving. Coming to other problems like multiple pregnancy, premature, low birth weight babies, etc., they come with a basket of their own problems. This is we are supposed to counsel when we have put more embryos in these women, like feeding problems, the weight problems, the social problems like not able to sleep. The mother is not able to sleep. She's more than tired. The social isolation of the mother, she's so much involved with the care of the low birth weight baby that she cannot attend any social event. She cannot go to any social gathering. The financial difficulties are very, very important, which are most of the times neglected or underestimated. OHSS, I have made a separate slide of OHSS because it is most of the times in the present era, it is most of the times an iatrogenic issue. So watch carefully and instruct the patients to report the early signals as I have told previously. Monitor them carefully whether we have admitted them or not. We can monitor even on phone. How are you? How is your quantity of urine? How many times you are passing? Any other new problems? Nausea, bloating of abdomen? Have you monitored your weight, etc. Hospitalization in these cases of OHS and sometimes too early, but definitely it is justified. It should be very and of the goals depending on the life situation of the patient. Some people may be married, but some may even be single or lesbian women. Third party reproduction, older parenthood, and sometimes when it is accepting parenthood of a second child after a very long gap. The first child may be even 15 years, but now they want to go for a second issue, which may be very difficult for them to adjust. Making decisions regarding the continuation or termination of the treatment itself. The single parents, sometimes divorced parents, gay father with the surrogacy help. So these are the special situations where counseling also should be tailor-made, and it is the special counseling which is required. However, counseling will frequently address issues outside the treatment context. It may be used to discuss the alternatives to parenthood, as I have already told, like adoption or fostering, to identify ways of living a meaningful and a cherished life and fulfilling life without children. Also, they should think of it is not that children always, sometimes they may not be able to produce any offspring. Parenthood against a backdrop of reproductive laws and highly technical medical conception. This is a highly technical medical conception because we would have made so many things on her. Require a special psychological preparation, education, and adjustment to its special joys and challenges. Similarly, the children should not be underestimated. The impact on children created through these ARTs have become an increasing focus of attention for infertility counselors. Not the parents, not the couples, we have to think of children also. Coming to some other additional situations like gamete or embryo donation. There are many psychosocial and legal implications for all people involved in the potential creation of a family where donated gametes or embryos are used. Donors need to consider their reason for donating, why I am donating my embryos. I mean the egg or the sperms, the risks involved in donation, their rights, and do I hold any legal status in this? They should know all the problems. The embryo donors, those patients who decide that they wish to donate their embryos to another couple rather than allow them to perish or be used for research purpose, will need to consider, they have decided to donate, they should consider whether they are quite sure they will not want the embryos for future use, how they feel about the real possibility that there may be a replica of their own children, replica, that there may be other children alive somewhere, sometime in the future, who are the result of their own genetic material. Curious about the identity of recipients, who has received my embryos, not knowing whether the donation has been successful, what was the result of my donation. Some donating couples have found it difficult to accept that there may be children alive resulting from their embryos who might show similar characteristics to their own children. It's difficult to digest sometimes. Some have expressed the fear of expecting to recognize such similarities. Some potential donors have not been able to feel comfortable with donating their embryos, and they say that destroy my embryos. Recipients of gamete or embryos. The risk of dropout of egg donor just before or even during the treatment is considerable. Recipient will be thinking all the time that somebody is donating the egg or even the embryo, but there may be sudden dropout. Also, the recipients need to be prepared for the possibility that no oocyte will be available. So they cannot continue in this matter. Patients who received the donor gametes have a lot of worries and anxiety about the consequences of the use of donor material, the genetic material, for the future father and child or the mother and child relationship, however the situation is. They're counseled about the matters such as anonymity of the donor, the legal parenthood, the parental responsibility, and informing the potential child of its origin, some special situations. Moreover, during pregnancy, anonymous gamete or the embryo can introduce curiosity about the donor, anxiety about the donor's health. Was the donor healthy? What was their genetic background? Anxiety about the physical characteristics of the baby, and sometimes even a sense of alienation from the child to be born. Some issues of recipients. A few more slides, that's all. Recipients of the donor embryos may have specific concerns such as, has adequate genetic health screening of the donors been done, especially about the serology or the chromosome part of it? Is there any incidence of physical, mental, or genetic disorders within their family? What is the intelligence, social background of the donor? What are the motives of the donors? Why did they donate their embryos? Is it for monetary benefits? Must they or should they tell the child born as a result of embryo donation about the fact? There are normally feelings of loss associated with not being able to accomplish this, some sense of guilt without assistance, and a third party being necessary to accomplish this. Purpose of counseling is to overcome this guilt feeling. Confidentiality. Curious about the donor identity. The recipients are often concerned about how they should tell their child about his or her conception. Who were the donors? In most countries, complete confidentiality is observed, but the child has the right to know the identity of the donors and their birth details on reaching age of 18. And this might affect the relationship and dynamics in the family of the donor as well as recipient once the child comes to know about this. The ability to accept the embryo donation is not always equal on both sides. The husband and wife both may not take it in the same spirit. Surprisingly, it's often the male partner who faces more difficulty in accepting this fact of embryo donation. When it is embryo donation, the woman will somehow compensate it by carrying the child and giving birth. Surrogacy. In addition to the usual skills of infertility counseling, the counselor in surrogacy cases must have a detailed knowledge and critically needs to address all the issues in surrogacy like acceptance, emotional preparedness, and psychosocial consequences of surrogacy of all those involved in like surrogate mother and the commissioned couple. The current and the future potential implications of surrogacy, the legalities, who is going to be the legal parents, and the legal situation which prevails in that country, the welfare of the child born. Gestational carrier, some more issues. Surrogate will never be able to forget that she has given birth to another child who is handed over to the commissioning couple. She will never forget. Any regrets should be compensated by the knowledge of happiness that she has done something good to somebody. Complication in pregnancy should be explained to the surrogate. Postnatal depression and lactation suppression are other challenging situations. No pregnancy is immune from complications, as all of us know, and same thing may happen in surrogacy also, but here the surrogate woman has no child to compensate for this. Abnormalities with the possibilities of termination of pregnancy also can happen in the journey and cause distress to all the parties concerned, commissioning couple, the surrogate mother, and the ART specialist. Failure of treatment like miscarriage is particularly very distressing and unanticipated. Surrogacy arrangements between friends or relatives can cause further emotional problems. Coming to fertility preservation, where gamete or embryo preservation occurs as a consequence of oncological diagnosis, patients are likely to experience, need not be oncological diagnosis alone, but most of the times that is so. Patients are likely to experience stress in facing both. They have their own life-threatening problems because the diagnosis of some cancer is made. Other than that, the additional problem of fertility restoration. Focus on emotional and physical issues is very necessary as a part of counseling. The need to preserve the sperm or the eggs and the urgency of this. It is not like any other case. It's not like a social preservation. This matter is very urgent because she or he is supposed to go next for radiotherapy or chemotherapy, and that is very urgent. The reactions of the patient's partner and other relevant social contacts also to be considered, like mother or father or even the intended husband. Options of ART open to them in the future and the potential of their failure. It may not succeed every time. The legal implications of fertility preservation. Possibility of cancer reoccurrence after a potential child is born. This also we should explain. The implications of the posthumous use of the sperm by bereaved woman. This is also another important issue. Feelings about the possible disposal of any remaining preserved gametes. Coming to social freezing. Counseling for a woman who has requested social egg freezing. Egg freezing by a woman who may not be in a secure relationship now, but wants to, she prefers to store her embryos, maybe a case of premature ovarian failure, or maybe social, for some other social reason, like she wants to go abroad or job related, and so many other social factors. And if the right man comes along, then she may go for further procedure. Should cover a range of specified psychological issues. Possible future treatment failure also should be explained to her, and eventual disposal of unused stored eggs. Counseling the donors and surrogates. There are so many issues here, as I've already mentioned, just to compile them. The psychological issues, their legal rights have to be spoken in detail, the monetary arrangements, the treatment information, all the vital points should be explained. Ultimately, coming to the summary, it's a very, very vast topic. I have just given a bird's eye view and touched upon only some certain situations. Please excuse me for that, as it is a very elaborate topic. The fertility clinic should aim to address the psychosocial and the emotional needs of their parents, not only so many other factors which I have already mentioned. This aim can be achieved by ensuring that psychosocial care is provided throughout the treatment experience. The basic aim of any counseling is to ensure that patients understand the implication, very important. They should understand what we are doing of their treatment choice, receive sufficient emotional support, and can cope up in a healthy way with the consequences of the infertility experience, whatever may be the result. A more holistic approach to the patient care is believed to improve the health outcomes, of course, increase the patient and team satisfaction, reduce the negative psychosocial reactions, and of course, very important, the medico-legal problems, and help the patients better come to terms with their past experience, whatever they may be. Pre-IVF counseling is very important, as important the actual treatment is. Actually, this is more important than the medical treatment what we give. Psychological satisfaction reduces the dropout rates, like anything, to a very significant extent. Always remember that for each patient you see, you may be the only person in their life. She may not have anybody, even not husband, listening to her in their life, capable of both hearing their pain as well as hand-holding. If that isn't sacred, I don't know what else is. Thank you all for your patient listening. Thank you so much.
Ma'am, thank you so much for a very wonderful, elaborate talk, ma'am.
Thank you.
Any questions from the audience for ma'am, doctors?
Any questions, please? I hope I'm very, very clear.
Yes, yes, ma'am.
So no questions.
Covered all the aspects, being very
Yeah,
practical at the same
it's a
time.
very, very elaborate topic. So
Yes,
I don't know whether I made justice. Tried my level best.
definitely, ma'am. I think it was very, very useful for all the audience as well.
Thank you. Any questions? Can I stop sharing my screen?
Yes, ma'am. Yes, ma'am. Absolutely. Ma'am, there's one question. The doctor's name is not mentioned. How many sessions can be provided for a couple, ma'am?
There is no actually number of sessions fixed. As many sessions as possible. At least for a few minutes we are supposed to talk to her and or the couple each time, because they should not go home left unexplained what has happened. As I have mentioned in one of my slides, sessions are very compulsory. Pre IVF, soon after pickup, soon after the embryo transfer, and the result, what happened to the beta HCG result. These four are very definitely required, compulsory. Rest as many as you can. You have time, your facility, the counselors you have, the nurses or staff, whoever can talk to her. She'll be happy to listen to us.
Thank you,
I
ma'am.
hope I'm clear.
Yes, ma'am. Ma'am, I had one question, ma'am.
Yeah.
Currently, ma'am, I think we are just emerging from this COVID times, and everything is going to be changed.
Yeah.
So, when patients are returning for infertility practices, for infertility treatment, etc.,
Yeah.
are there any specific tips for doctors, ma'am, in these times from your experience?
No particular specific instructions, but we have had many COVID sessions in ART. We are supposed to follow that, in the sense, other than our social distancing and all that. And as far as possible, what I'm doing is, other than the regular instructions, my cryo cans are kept different. And whatever I follow in the OT, the social distancing, even the embryologist explains to the patient about these things. And the cryo cans we keep when it is a freezing different, and we explain to the patient that you are doing the corona time. Also, if they're happy to postpone their cycle, say another 2 months, because we don't know, it is still under trial, especially about what is going to happen to the egg, whether the coronavirus is going to attach to the sperm. It's not known so far. What is going to happen to the embryos? Certain loose ends are still there. Explain all these things, and then tell them to go for IVF. If they are a young age patient, can probably, once the matter is more clear, the cloud is gone, that would be a better situation for them to go for a treatment. Because the treatment or the vaccine, either of them have not arrived yet. We can't vaccinate her and then take her for a cycle. It's not so.
Thank you, ma'am. Any more questions to ma'am, doctors? So actually, ma'am, with no further questions, I would like to thank you on behalf of Shield Healthcare and the audience. I know you always put in a lot of preparation to give such elaborate talks, and covering all the things right from pre-IVF to during IVF and after IVF. Thank you so much, ma'am, on behalf of Shield Healthcare for this webinar.
Thank you, Dr. Kiran. Thank you, Shield Pharma, and all the audience for spending your Sunday evening with me. That was a great time. I hope I was of some use to all of you in elaborating on this counseling session. Thank you so much.
Thank you, ma'am. Dr. Rekha, ma'am. I am Kumar on behalf of Shield. I joined Dr. Kiran and the audience, esteemed audience, in thanking you today.
Yeah. Can you show yourself video?
Just a moment,
if
ma'am.
possible. Yeah.
Very good evening, ma'am. And thanks to Sanjay, to who you had sent messages, and we had the good fortune of listening to you more than once.
Yeah.
Thank you, ma'am.
Thank you so much. That was a great time.
Thank you, ma'am.
Can I close my audio and video?
Yes, ma'am.
Thank you.